Hello and good day. My name is Teacher JV, and today we will be learning our first topic for our subject critical care nursing. And we all know that we already have foundation of what we're going to talk today, in which it is all about your cardiovascular system and the following diseases or illness that associated with it. Okay, so let's start. So, in order for us to have a great understanding on the illnesses and ailments or diseases associated with the heart, we must have a background or a preview of the anatomy and physiology of the cardiovascular system. And as we all know, and we've learned already in our first years, that the heart, which is this one, it is located at the center of the thorax, which occupies the space between your lungs. We have two lungs as well as your diaphragm. So the central part of our body, it is where our heart is located. And they're saying that the heart is actually 300 grams or 10.6 ounces in terms of its weight. Well, there are myriads of factors affecting this one. It can depend on the age of a person. Of course, if we're going to compare it with a newborn to an adult, of course, the adult has a what we call, heavier. The heart is heavier, of course, compared to the newborn babies. Another factor is your gender, if it's a male or a female, the body weight, the body mass index, if a person is obese or overweight, or if a person is, anorexic or very thin. It can also be associated with the size and weight of the heart. The physical activities as well, especially to people who are outdoorsy or, very sporty. Athletes has actually bigger heart compared to normal person. It's because of the strenuous activities they are doing, and the heart is compensating with those kind of activities, hence having bigger heart compared to ordinary people. And of course, if a person has a heart disease. Okay, and as we all know that the heart, it actually pumps the blood, supplying oxygen and other nutrients. Okay, now let's move on here. How about the layers of the heart? Most likely you already have a great foundation of this one. So we have your pericardium, which is the outermost layer of the heart. Your myocardium, it is the middle layer that contains your heart muscles, and of course the innermost layer that lines the heart is what we call as your endocardium. And you have a solid foundation of this one. It's because you've learned this one in your first year as student nurses. So peri, it means like around, myo, it means like, the middle part, and your endo is the inner part. And what I want you to remember here, in your pericardium, it consists of two thin fibrous protective layer that contains fluid, to protect them from friction. And whenever accidents happen or, other form of mishaps, it will provide cushion and also away from jarring. Okay, so these are your layers of the heart. How about the heart chambers? If we say heart chambers, of course, it will pop up to your mind the left and right atrium and your left and right ventricle. And of course, associated with this is your systole and your diastole. Okay, and whenever we say your diastole, it is your relaxation phase. Okay, wherein the ventricle, the chambers will relax so that the feeling of the blood will exist. Okay, what is happening during your relaxation phase or your diastole phase? All of these four chambers relaxes simultaneously. Okay, so all of them will relax simultaneously, allowing the ventricles, this one, to be filled in preparation for contraction. Whereas in your systole, contraction of the atria and the ventricles, they do not function simultaneously. Okay? Now here, your right atrium and then your right ventricle, they distribute venous blood, or we know as your deoxygenated blood, to your lungs via your pulmonary artery. Your right atrium here, it receives the venous blood returning to the heart from your superior vena cava, which supplies the upper portion of our body, the head, the trunk, the head, the neck, and the upper extremities. While your inferior vena cava, it supplies your trunk and your lower extremities via your coronary sinus. Now let's move on here to the other part, your left atrium. This one, it distributes your oxygenated blood to the rest of the body via your aorta. In your left ventricle here, your left atrium, it receives the oxygenated blood from your pulmonary circulation via your 4 pulmonary veins. So these are the heart chambers. How about your heart valves? Okay, so most likely you've known this one already. So we have 4 valves of the heart which permit the blood flow in only one direction. So we have your tricuspid, your mitral, your pulmonary, and your aortic valve. So they're like gates which allows blood to enter and exit. Okay, so during your diastole, your tricuspid valve, this one, and your mitral valve, they actually open. Okay, they will open to allow the blood to flow freely in your relaxed ventricles. So again, during your diastole, the relaxation phase, these 2 valves will open so that blood will flow. Okay, while your semilunar closes during your diastole. Okay, and they open during your systole. Next one is your cardiac electrophysiology. Most likely you've read this one already. So we have your SA node. We also have your SA node, the primary pacemaker of the heart, the AV node, the bundle of His, the right or left bundle branch, and of course your Purkinje fibers. And what I want you to remember also are these terms. We have your automaticity. It means like the ability to initiate an electrical impulse, while your excitability is the ability to respond to an electrical impulse. Your conductivity is to transmit an electrical impulse from one cell to another, while your contractility is the ability of the cardiac muscle to shorten in response to depolarization. And the last one is your rhythmicity. It is the ability of the cardiac cell to spontaneously generate an action potential at a regular rate. Okay, moving on here. Your rhythmicity and pacing, your SA node discharges normally in an adult at a resting rate of 60 to 100 times per minute, while your AV node discharges at a rate of 40 to 60 per minute. Factors for this one: the slower the rate, the less able are the ventricles to meet the perfusion needs of the body during exercise or activities of daily living. And a very rapid ventricular rhythm also compromises perfusion needs because of the shorter the diastole, the less time for filling of the chambers. And decreased ventricular filling reduces your cardiac output. So these are the factors on how the cardiac output or any heart activity is being affected. Now let's go here. The electrolytes in cardiology. These electrolytes actually are very important to maintain, not so much and not too short as well. So there should be an equal distribution, or at least they are on the normal range. If it's because, there are um, associated imbalances that can occur whenever there are less sodium, more potassium, less BUN, more CREA. Okay, so I think you learned this one in your medical and surgical nursing, especially in fluids and electrolytes. Okay, let's go here. If we say your potassium, your sodium, and calcium, they actually play a crucial role in the function of your myocardium. And the movement of these ions across your semi-permeable myocardial membrane causes the voltage across the membrane to exceed a threshold and generate an action potential, resulting in what? In your muscle contraction. Okay, and with this one, the imbalance of these electrolytes can have detrimental effects of the heart, which can actually cause, or it can contribute to, arrhythmia and your cardiac arrest. That is why when we do activities or strenuous activities, we are doing our sports, we should have always our water or any drinking, supplements, maybe like Gatorade, so that the electrolytes and ions that we sweat out will be replenished. Okay, now let's go here. Your cardiac output. Your cardiac output, this is a traditional measure of your cardiac function. It is the amount of the blood in liters, and it is being ejected from your left ventricle each minute. So the cardiac output is the product of your, as you can see here, our equation, heart rate multiplied by your stroke volume. Okay, and other resources, they're saying that the normal value of cardiac output is 4 to 6 liters per minute. Others saying that it is 4 to 8 liters per minute. Maybe it's safe to say that the normal value is 4 to 8 liters per minute. Okay, and there are factors affecting your heart rate and factors affecting your stroke volume. Here, this is a sample computation of your cardiac output. Samantha Stride runs 5 miles daily, and she is 150 centimeters tall and has an ESV of 45 ml per beat. Her resting heart rate is 75 beats per minute. Her ejection fraction is 59%. It is below the average, and her resting SV, or stroke volume, will equal to 65 ml per beat. Calculate her Q, which is the cardiac output, in ml per minute and liters per minute. So just put all the given numbers here so that you can properly calculate. So this one will end to 4,875 ml per minute. So the cardiac output here, we're going to convert this ml into liters. So it will become 4.88 liters. So as simple as that on how are you going to calculate your cardiac output. Now, there's another thing here to measure your cardiac function. So a while ago, we've already talked about your cardiac output, in which it is your stroke volume and your heart rate. While your cardiac index, we have additional factor, which is it is the patient's body surface area, and with that we are computing it in your in your square meters. Okay, so your cardiac index typically averages 3 plus 0.2 liters per minute and ranges 2.8 to 4.21 minutes per square meter. So the equation will be cardiac index will equal to cardiac output plus or multiply by your body surface area. Okay, we have here another one, your BSA, or known as your Mosteller formula. in which you're going to take the square root of the highest height, of the height in centimeter multiplied by your weight in kilogram, and we have a constant number here, divided by 3,600. So example is in here, so just put all the given numbers and then multiply height by weight and divide by 3,600. The answer will become 5. Take the square root of 5, will be 2.24 square meters. So this is another computation. Moving on here, we have your preload and afterload. Most likely you already know this one. So preload is the amount of the stretch places on a cardiac muscle fiber just before your systole. And your afterload, it is the end load against which the heart contracts and ejects blood. How about your MAP or your MAP? Okay, if we talk about this one, it's all about your mean arterial pressure. Your mean arterial pressure calculation is very easy. Okay, so you will just do a constant of 2 multiplied by your DBP, your diastolic blood pressure, plus your systolic blood pressure divided by 3. So you put all the given 110, 60 times 2 plus 110 divided by 3, it will have 76.67, and it is on your normal range, which is 70 to 100 milligram per mercury. Okay, this is to evaluate your mean arterial pressure. Is used to evaluate perfusion of your vital organs. I hope everything is clear so far, so that we can go here. How about your pulse versus your pulse pressure? Your pulse is the rhythmic dilation of an artery that results from beating of the heart, while your pulse pressure is the difference between your systolic and diastolic blood pressure. So normal value, of course, in the pulse, it will differ on the age of the client. For adult, it's like 60 to 90 or 60 to 100, and 120 for newborns and above. Okay, but here the normal average for adult person is 72 per minute, while the pulse pressure is 40 for an average. The unit is number per minute for pulse and millimeter per mercury for your pulse pressure. Okay, how about this one? Most likely we've done this kind of activity or technique, the Valsalva maneuver. As you can see here in the first part, it occurs when you hold your breath and you bear down, especially if you are doing defecation or heavy lifting, if you are going or attending gym. Okay, and bearing down actually increases your intramuscular and intrathoracic pressure, which decreases the venous return to the right atrium and ventricle, and with that it will result to your heart rate being slowed down. And whenever you're how will I say this one, you're bearing down, when you defecate, bearing down also stimulates your vagus nerve. Okay, and once your vagus nerve is stimulated, it will result to slower heart rate. Okay, the second picture here, the second illustration, this one, we are doing this one on exhalation. Okay, especially whenever we go to high altitude places such as Baguio City or Tagaytay, just to remove the clogged ears, we are doing this type of Valsalva maneuver. Okay, and this part here, this is your central venous pressure monitoring, or your CVP, and I think Mom Arsenia already discussed some of this one, and I think she will discuss it to you on detail once you will be having class with her, especially on the RLE. Okay, But as you can see here, your CVP actually reflects the pressure of the blood in the right atrium and provides information about your intravascular blood volume. Okay, so what is happening here is, they are typically measured in your superior vena cava near the right atrium via a catheter. So you can see here, this one, there's a catheter in your jugular. It can be in jugular or in your subclavian vein. Okay, and the best insertion site to minimize infection with this one is actually in your subclavian vein. Okay, the normal CVP is less than 8 millimeter mercury, or 2 to 8. Okay, the average is 2 to 8. And the lower your CVP can indicate actually your hypovolemic shock, which requires fluid therapy. Okay, if it's high, the common cause are the right ventricular failure or your hypervolemia and mechanical ventilation. As we all know, if there's an opening of the body, complications such as infection can occur for patient. That is why we really need to take care of this, of this area of the heart or of the body, so that infection will not manifest, or we will minimize the occurrence of your infection. And if there are opening, there are tubings just like this one. Possible complication as well are thrombosis and your air embolism. Okay, I think I attached a video in your Google Classroom in order for you to properly visualize the CVP insertion and the CVP monitoring. So please go to your Google Classroom to see this part here. Okay, let's move on here. So it's just like this one. And these things here, they're just good to read. Maybe I'll just send you this part. Okay, how about your assessment? How are we going to properly assess our client? Of course, you've been through this one. It's because you already exposed to the hospital, and of course you've learned the theory on health assessment subject. So the PQRAST is of course the one that we're going to follow in order for us to have a greater assessment and to help our clients recover. So the parameters are these questions. N stands for normal. They describe normal baseline. What is it's like before the symptom develop? So you're going to divulge information, or you're going to probe the clients in order for them to speak and to give you ideas and proper sequence on the occurrence, especially related to cardiovascular disease. And you're going to ask also some precipitating and palliative factors, such as what seems to trigger it, what makes the symptoms worse, what have you tried so far, what measures did not relieve the symptoms. Maybe it can be brought by emotion. You can ask, what are you doing, or who's with you? Are you in normal state of emotion? Are you angry that time? Are you happy, or are you sad? And when you feel that there is something wrong, what are the things that you've done? Is it deep breathing? Is it sitting, pursed sleep breathing? Did you take any medication? Those factors that you really need to ask the clients. The quality and the quantity, how does it feel? How would you describe it? There are different types of pain, as you already know, and it is more or less than you expecting now. Is it more or less than you experience at any other time? Region and radiation, where does the symptoms occur? Can you show it to me? Does it travel anywhere, such as down to your arm or in your back? It's because if these things happen, it can be an indication of stroke, right? So you should always properly ask this kind of questions to your clients. The severity, you already know this one. Pain scale, you always do this one in your nursing care plan. From 0 to 10, 0 is the lowest and 10 is the um, the highest in terms of the feeling of pain? Does it force you to stop your activity and sit down, lie down, or slow down? Is the symptom getting better or worse, or staying about the same time? And of course, the last one is the time. How long does the symptom last? How often do you get the symptom, and how it occur in association with anything such as before, during, or after? This kind of template that you are going to ask your client will definitely help you to gather information. And of course, you will be having a subtle and definite subjective and objective data in which it will help you to make your nursing diagnosis. And of course, if you have a solid nursing diagnosis, it's easier for you now to do your plan, your intervention, and of course your evaluation. So these are just the gist of how are you going to assess your clients. And of course, in order for you to have a great assessment, you should master communication skills, to the fact that you have to go to the level of your client on how are they going to respond to you, on how are you going to gather information. Now let's move on here. In terms of your assessment, we have your the most common one is of course the chest pain, but we should know how to segregate or separate and distinguish the different kind of chest pain. So we have your angina pectoris, your coronary artery disease or your CAD, we have your pericarditis, and your pulmonary embolism. So your angina results as an imbalance between your oxygen supply and demand, and usually develops over time. While your CAD, they often precipitated by your physical, emotional exertion, a meal, or being out in the cold. While your pericarditis, we all know that itis means inflammation, pain made worse lying down, moving, or deep breathing. And the last one is your pulmonary embolism. It is your retrosternal accompanied by SOB and your peripheral cyanosis. So let's discuss this one by one. So we have your dyspnea. Most likely all of you felt this one. This is the inefficient pumping of the left ventricle, which causes the congestion of the blood flow in the lungs. Okay, so the subject complaint with this one is exertion at rest, exertion or at rest. Like nahihirapan kayong huminga even though you are sitting or you are doing nothing. Okay, the causes for this one, of course, are like medication, allergies. If you took a medicine or eaten something that is not good for you, and sometimes it will lead to dyspnea. Another common cause nowadays, especially during the times of the pandemic, is your anxiety. Anxiety can lead to shortness of breath, okay? And other thing is infection. So what we're going to do here is to, as much as possible, make our clients relax and do pursed lip breathing so that their muscles will relax as well and the proper inhalation and exhalation will be done. Okay, but how about your orthopnea? You already know the word orthopnea. This is the patient lies flat, relieved by sitting or standing. Once the patient is at his or her back, difficulty of breathing will occur. Okay, so the signs and symptoms here: breathing improves when sitting or standing, needing multiple pillows when sleeping. Then there's gonna be abnormal breath sounds such as your wheezes, your ralls, your dullness, to percussion, chest pain, or coughing. These things you already know these ones. Okay. How about your paroxysmal nocturnal dyspnea? What is happening here is that patient is lying down, sleeping, and then breathing difficulty after 1 to 2 hours. Okay, and then how are they being relieved is that when they sit upright or getting out of the bed. And once they go back again to the bed, few hours again, there's going to be um, difficulty of breathing. Okay, what is happening here is that there's going to be dyspnea, cough, frothy, sputum, pallor, sweating, tachycardia, and freckles. Because as you can see here, the fluid redistributed into the lungs. So if there's like a lot of fluids, there's going to be crackles, and then there's going to be cough. Okay. Other thing that we can actually assess to clients is having your edema. Okay, so we have your pitting and non-pitting edema, and it's this part here you can actually properly grade the edema depending on its severity. Okay, palpitations. Sometimes this is being brought by anxiety as well, especially if you're going to, going for the first time on duty, or you're going to take a quiz, you're going to ride by yourself, or transportation, you will travel alone, palpitation will actually occur. And of course, brought by stress, by alcohol, by tobacco consumption, and of course, caffeine. All of us here are coffee lovers, most likely, but it can actually lead to heart palpitations. Now, the next here is your syncope. Now, if we say syncope, this refers to the sudden loss of consciousness. Yung mga tao na bigla na lang nahihimatay. Okay? What is happening here is there's a temporary decrease in the blood flow supplying in our brain. Okay? So, with this one, it can actually result in the temporary decreased blood flow supplying the brain, which is one. Prodrome usually associated with triggering event, maybe emotion, or stress, something like that, or the environment itself. Okay, so when syncope happen and it is associated with intense emotion, we call it as your vasovagal syncope or reflex syncope. Again, I'll repeat that one. If it's being triggered by an intense emotion, it is called as your vasovagal syncope or your reflex syncope. Okay? And as you can see here, we also have your dizziness. Dizziness usually occurs if we lack sleep, or we have hangover, or we were hit by something, bump into something maybe. So there are 4 types of dizziness. We have your vertigo, your lightheadedness, disequilibrium, and your pre-syncope. Okay, so just read the definitions of this one and you will understand their differences. How about this one? Cough and hemoptysis. We all know that a cough is quite normal and we can understand that one. But what if there's blood in your cough, and that is what you already called as your hemoptysis. Okay, so maybe these are side effects of medication such as your ACE inhibitors or your angiotensin converting enzyme inhibitors. Example medication that has pril at the end, such as your captopril or your ramipril. These are the side effects. It can be dry or wet, and frequency in terms of the frequency of the cough. Okay, now let's move on here. How about nocturia? Nocturia, these are frequent urination at night, especially to older clients. Okay, and this can be associated with cardiovascular system as well. That's just your urinary system. Okay, and maybe because of the use of diuretics. So they are having trouble sleeping at night because they will go out of bed to do urination. Now let's move on here. How about your cyanosis? I think you already know the cyanosis, bluish discoloration of our body because of low or ineffective tissue perfusion. And in terms of etiology of this one, we can use the the acronym or the how will I say this one? Mnemonics, cold palms. Okay, so we have your peripheral and your central cyanosis. If we talk about your central cyanosis, these are generally distributed and best found by examining the mucous membranes for discoloration and duskiness, and reflex reduce in our oxygen concentration. While your peripheral cyanosis, this is localized. It can be seen on extremities, on our hands and on our feet. Okay, it can also be seen sometimes on the ears, on the lips, and on the nose. And sometimes peripheral cyanosis is normal, especially if you're living in a cold place like Baguio or Tagaytay, or places with winter season. Okay, so in peripheral cyanosis, it can be associated with cold, just like what I've mentioned a while ago. It can be associated with your obstruction. Of course, if there's an obstruction, there's limited blood supply because there are occluded veins or arteries. And then what is happening is that supply of the blood is decreased and tissue perfusion also decreases. You also have your left ventricular failure. It usually occurs if there is a dysfunction of the left ventricle, which causes insufficient delivery of blood to the vital organs. Also have shock and of course decreased cardiac output. So that is the mnemonics for your peripheral cyanosis. Now let's move on to your central cyanosis. We have your polycythemia, usually blood cancer. It causes your bone marrow to make too many red blood cells, and then the excess cells actually thickens the blood and slowing it to flow. And with that, it can cause serious problems such as your blood clots. And of course, we already know if there are blood clots, there's going to be obstruction, decrease of blood flow, decreased tissue perfusion, and then manifestation of your cyanosis. Okay, as simple as that. Now, how about your lung disease? Altitude, cold places, lung disease as well. And your M is your methylhemoglobinemia. Okay, that's too difficult to pronounce, but please have some practice to say that one. I can't even say it by myself. Okay, your sulfimoglobinemia. This is a rare condition in which there is an excess of your sulfiglobin. Okay, now this one is actually a pigment, the greenish pigment of our blood, which cannot be converted back to normal. Okay, and causes your cyanosis at low blood level. We also have the shunt. I hope you already assisted maybe or have seen a shunt operation or insertion. You know, this is they're going to put a drainage system on the brain so that the excess CSF or cerebrospinal fluid will be drained or redirected to other location of the body in which it can be reabsorbed. Okay, let's go here. We also have your extreme pain or paresthesias. Okay, so this one results when the blood supply to exercising muscles, and then it will manifest to your hands, to your feet, and other parts of the body. And inadequate, and this type of pain is what we call as your claudication. Okay, claudication is the pain that is caused by reduced blood flow to your legs. It can also be seen on your arms. And please remember that claudication is not a disease, but rather a symptom of the disease. Next one here, we have your pitting edema and non-pitting edema. You are already familiar with this one. And this poor guy here is experiencing your anasarca. Anasarca is your generalized edema. So now the whole body is actually inflamed. Okay, sometimes it can be you can use your amlodipine, verapamil, dichalisim. I forgot that one. I think that is your cardizem. Let's go here. Pitting edema, you already know this one. We can cardiac, renal disease associated as well. This one, cardiovascular system assessment. Of course, it can be associated from your past health history, and you can actually, go into these details with your clients to have greater view on the onset of the cardiovascular, disease. And we all know that some of these diseases associated are family health related. Maybe the grandfather, father, or other relatives have this one as well. Personal and social history. What if it is being affected with the things that you are doing in your life? We also have your review of other system, the typical head-to-toe assessment, cephalocaudal assessment. You should be doing this one to your clients. Physical examination. In terms of this one, we will do inspection, the general appearance, posture, gait, jugular venous distension, the chest, the point of maximal impulse, and of course your extremities. Just like this one, I think Ma'am Arsenia will help you how to properly place the leads for your ECG, so that there's gonna be an proper ECG reading. Okay, you will be doing this one on your RLE, as well as inspection, physical palpation, precordium, percussion. These things, it will be discussed properly. Physical examination, auscultation is very important for your cardiovascular disease. So, the S1, S2 sound, your lub-dub sound. Sometimes there's gonna be S3 and S4 as well, lub-dub-dub. So you will be learning this one as well. Also, we have your S4, the atrial gallop, is a low frequency sound heard late in your diastole just before your S1, and other heart murmurs that you're going to properly use or properly utilize in order for you to distinguish the normal sound from your abnormal sounds. And maybe I will be sharing some videos of this one for us to be able to appreciate it. Okay, and this will be the end of our first part of our lecture, and we will be continuing this one next time. I hope you learned something, and stay awesome. Goodbye, guys.